All right, thanks for sticking around. So, flow starvation is a type of ventilator dyssynchrony, and it's one that can cause problems with patients. Number one, patients clearly are not getting what they want from the ventilator. They're flow starved. So we, as the ones who set those settings on the ventilator, are not giving the patient what they're trying to get from the ventilator. So it's uncomfortable for the patient. In addition to that, it can cause a degree of respiratory compromise, especially if it gets more significant. So what is flow starvation? To start, we have three different waveforms here. Of note, we're going to be talking about flow starvation from the ventilator settings of volume control. So VC, AC is how it's set on some vents, but volume control rather than pressure control, meaning you set the volume the patient is going to receive. And what volume control normal scalars or waveforms look like are set right here and drawn out. This is the pressure scalar, right? So you have this set pressure, the PEEP, and the ventilator increases the pressure as they're getting a breath. It kind of flans out here and continues to increase as they're getting a breath. Breath's done, it goes down to the set PEEP, which is the lowest pressure, the end expiratory pressure, and then a new breath starts. So each one of these is a breath, and that's a normal pressure scalar in someone in volume control. Here's the flow scalar. Flow goes up, pauses, flow goes down, normalizes, up, pauses, down, normalizes, and this is one breath as well. And then the volume scalar makes intuitive sense. Volume goes up, volume starts to go down back to zero. And this is in regards to time. So the horizontal axis here is time. Again, check out that previous video, the introduction to basic scalar concepts. If this is confusing to you, if you're like, I'm good, I understand these things, then continue on in this video. What happens to the scalars or waveforms during flow starvation? Because that is how you diagnose flow starvation, is by looking particularly at the pressure scalar. So what happens in flow starvation to the pressure scalar is you have your normal, this is your just PEEP, there's no breath. The patient has a slight negative dip in their pressure scalar, meaning they're initiating a breath, right? They're sucking in, they're causing a negative intrathoracic pressure, so you often see the pressure dip just a little negative. Then they get their breath, and during this area where the pressure usually flattens out, what happens is they actually start to get this negative kind of dip, and then the pressure will go up again and come down. Compare that to here where you have this smooth line, and then think about it conceptually. What is this negative dip? Well, this is a pressure scalar, right? So anything that's going down means the pressure is going down. And when someone is initiating a breath, they're sucking in, right? Breathing in, their diaphragms contract and they have negative intrathoracic pressure. That's how their lungs inflate. And what's happening in flow starvation, and you can think about this, you can picture this, is that the patient's respiratory effort, that negative intrathoracic pressure that results from them inspiring, outpaces the flow that is filling up the lungs and being delivered. So negative, they start to take a breath. Breath starts to be pumped in, but they are inhaling faster than the flow is being delivered. So you see this kind of negative inflection as the flow is being delivered, and then the breath's done and it goes back to normal. This can get pretty severe, It can get to the point where, I don't know why I'm writing above the thing, but next breath, it can get to the point where this can come way down before it goes back up. And this here would be flow starvation. The flow is not keeping pace with how fast they want the flow, so they are having a negative intrathoracic pressure because they're breathing in. They're, sucking in through that endotracheal tube into their lungs. Their diaphragms are contracting, and it's happening faster than the flow is being delivered, which is why you get this negative deflection in the pressure scalar. The flow and volume scalars don't tend to really look any different, right? Because the flow is what's being delivered. This is just the flow that's being delivered on the ventilator, and the volume is the volume that they're receiving. So that will still look the same. What will look different is the pressure scalar, because their inspiratory efforts, the negative intrathoracic pressure they're prompting with their own breath, is outpacing the amount of flow being delivered. And if that flow is being delivered more quickly, you'd see they'd have a negative deflection, it'd come up, and now they're getting enough flow until the breath's done. So you don't get that negative inspiratory pressure because their lungs are filling up with air fast enough to keep up with their own negative inspiratory pressure, their negative inspiratory force. So that's what the scalar will look like. That's how you diagnose flow starvation. Instead of a nice kind of flat line here, you're going to get this negative dip. And it can be to different extents, from a slight, negative to a very significant negative dip. So what do we do about flow starvation then? Well, flow starvation, again, in volume control mode, flow is essentially a product of the volume that's being delivered at a certain rate, right? So if your tidal volume that you set on volume control, let's just say, is 500 cc's, the flow is going to be related to how fast that 500 cc's is being delivered, which makes sense, right? Because you're pushing in 500 cc's of air, and the flow is going to be the pace in which that 500 cc's is pushed in through the ventilator endotracheal tube into their lungs. And that, on most vents, is going to be then related to the inspiratory time, which we'll just say, let's say it's 1 second. So then the flow is going to be a product of the fact that you're pushing 500 cc's of air into their lung over 1 second. All right, normal is about 50 to 60 liters per minute of flow. And again, it's dependent on the tidal volume and the inspiratory time, the I time. And you can picture how this might change, right? So the example we used above is their tidal volume is 500 cc's, and their inspiratory time they get that tidal volume is 1 second. Now picture if we change that to 0.8 seconds. Would they get more or less flow? Think about that for a second. So you're getting 500 cc's of tidal volume, right? So we'll say 500 milliliters over 1 second in that initial one. So this is going to be, you can see 500 milliliters a second of flow. Whereas if you did 500 milliliters of air over 0.8 seconds, let's see if I have anything near me that I can do math on. I should have planned ahead for that. Here's my phone, the handheld calculator. You guys who are smart probably already did this in your head, but 500 milliliters over 0.8 seconds, this is going to be 625 milliliters of air over 1 second. So the flow is going to be higher because you decrease the I time, which is the time in which that breath is delivered. In addition to that, think about this third example down here. What if you increase the tidal volume to 600 milliliters, but you still delivered it over 1 second? Well, as you're probably picking up on, that would be 600 milliliters of tidal volume delivered over 1 second, which would equal 600 milliliters per second of flow. So solutions to flow starvation on the ventilator involve either increasing your tidal volume, right? If you go from 500 cc's to 600 cc's over the same 1 second, your flow is going to go up from 500 cc's per second to 600 cc's per second. Or you can decrease the inspiratory time, the I time, the time in which that breath is delivered, which we showed here, right? You're keeping 500 cc's, but you're delivering it over 0.8 seconds. So then the flow increases to 625 cc's per second. But what if you don't want to do that? And that's why this is clinical scenario dependent. So let's say that you have a person who is severe ARDS, severe acute respiratory distress syndrome. And we've covered ARDS a number of times. It's linked in our critical care playlist. We'll link it in the video description as well. And you want to make sure this patient is just getting 6 cc's of tidal volume per ideal body weight, per kg. That's one of the kind of ARDS endpoints, 6 cc's per kg of tidal volume or less, depending on the clinical scenario. So you don't want to increase their tidal volume, all right? And let's say for some reason you don't want to increase their inspiratory time. You think this is their lung protective ventilation. Well, you can consider then increasing their sedation or even doing neuromuscular blockade, paralytic, to decrease the patient's respiratory effort so that they no longer are inciting such an inspiratory effort that outpaces the flow that you're delivering the patient. And it really depends on the clinical scenario. Obviously, increasing sedation or doing a neuromuscular blockade paralytic is not something you want to just reach for no reason, just to make them look less flow starved, right? Those are big decisions that can affect patient outcomes. So that's kind of last-ditch effort if they're in a clinical scenario where you are being you're kind of in a tight spot on the ventilator and you can't adjust things. The ventilator adjustments that will help this patient are increasing their tidal volume or decreasing their inspiratory time to try to get that normal 50 to 60 liters per minute of flow or whatever that patient is needing. Typically, if they're on an appropriate tidal volume, let's say they're around 6 cc's per kg, I tend to try to decrease the I time first. Let's say the I time set at 1 second. I'll try decreasing it to 0.8 seconds or even go less than that and see if that gets rid of their flow starvation. It usually will, and if they tolerate that, okay, I'll leave that as is. If not, and if I think they will be all right with a higher tidal volume for lung protective strategy reasons, you can increase their tidal volume as well. And then in your back pocket, increasing sedation or paralytics, if the clinical scenario for other reasons demands it, will also probably help their flow starvation. But always start with ventilator adjustments, being increase the flow they're receiving by decreasing their inspiratory time or even increasing their tidal volume. All right, thanks for sticking around. So no further ado, ventilator dyssynchrony double triggering. Also known as premature cycling is another same verbiage or similar verbiage for the same topic. Some people call it breath stacking. Others call it short cycling. So a few different ways to all say the same thing, which is double triggering. But you might hear different people refer to it as different things. So those are all synonyms. And the way we diagnose this is using the scalars on the ventilator. And these are particularly the pressure time scalar, so pressure on the y-axis, time on the horizontal axis, the flow time scalar, or the volume time scalar. And it's always important to note what ventilator mode you're in when looking at these. And for the sake of this discussion, we're going to be in volume control mode, which is where you choose the tidal volume that you're delivering rather than pressure control mode. If these scalars don't look familiar to you, again, check out the video we linked in the video description, which is an introduction to understanding these scalars. If they look good and you're like ready to rock and roll, then you don't need to check that out, but that will be the foundation for this video. So the pressure time scalar. You get, when you're breathing on the ventilator, there's a few things that are set. One is the PEEP, right? The end expiratory pressure. And in volume control, then you set the tidal volume. What happens, the pressure control scalar, you always will have this end expiratory pressure, this PEEP. That's why it doesn't go down to zero pressure. You're always a little above zero. And then it initiates the breath. And as you could imagine, when the breath is started to push, when the volume is being pushed into the endotracheal tube, into your lungs, you're going to get an increase in the pressure those lungs are seeing that then kind of flattens out smoothly and then returns back down to that end expiratory pressure, that PEEP. The flow follows suit, right? You get an increase in flow when that pressure is being delivered, it plateaus, then you get a decrease in flow, but this is still positive flow. This is kind of negative flow going back out. And then what you will see, obviously, is the flow that was brought into the lungs is going to then flow out of the lungs back to the ventilator. So this is all one breath, right? One breath here, and then the volume, no surprise, volume goes up as the breath is being delivered. That volume is being delivered, and then it returns back to zero. Double triggering, though, what happens is two breaths are triggered back to back. So the first trigger is not surprising, right? You have your PEEP, as we talked about, and then the patient initiates a breath. When they initiate a breath, right, their diaphragm contracts just like you or I, and that decreases their intrathoracic pressure and would fill their lungs, but they have an endotracheal tube in. So the ventilator sees this decrease in pressure when they initiate a breath, this little negative inflection. And then the ventilator says, all right, they want a breath, I'm going to deliver the breath. So then they start to deliver the normal breath. But when it comes back down, it doesn't just go to the normal end expiratory pressure, that normal PEEP, right? It goes below that, you can see here. And what that is the patient is still trying to inspire, trying to continue to take their breath in. So you see that negative deflection again, and the vent says, oh shoot, they want another breath, so it gives them a second breath. And that is all in a row. They trigger 2 times or double trigger. And that's what this pressure scalar will look like for double triggering. So if we draw it out again, right, the patient's not breathing, they're just at their normal PEEP. They start to take a breath in, so the pressure gets a little bit negative as their diaphragms contract. The ventilator then says, hey, they want a breath. So the ventilator starts to pump volume in, which increases the pressure. It's a normal breath. The ventilator at this point says, I'm done giving the breath, but the patient is still inspiring in, so you get this negative deflection again because the patient is still trying to suck air through their endotracheal tube. The ventilator then says, hey, wait, they want another breath. It gives them another breath, which increases the pressure, and then they finally breathe out. The pressure is often higher during that double triggered breath because their lungs are still full of volume from the first breath. They never expired that volume out. Because of that, when you pile more air on top of the air already in their lungs, it's going to lead to an increased pressure as compared to the first breath, right? Because you have twice as much volume in the lungs, so you're going to see a higher pressure during that second double triggered breath. And that is what the pressure scalar will look like for double triggering. The flow scalar will also follow a similar suit. So we talked about the normal flow scalar with a particular eye on the kind of a negative flow, or the flow returning back to the ventilator. Well, in double triggering, you get the normal flow scalar, right? Flow is going into the lungs, and then flow starts to slow down, but you never get this negative flow deflection that you see here because the patient is still breathing in. They're still trying to suck air in. They're not breathing out. So then you get a second flow scalar waveform before you get this big breath back out of the air flowing out of the lungs back to the ventilator. So the flow scalar will essentially just show 2 inspiratory flow waveforms without the normal expiratory flow because that patient has not breathed out yet. And what this will mean for the volume in the lungs, we put right here. The ventilator will count this as 2 breaths because they think they're delivering 2 breaths. But the expiratory volume, the tidal volume expiratory, the VTE, will actually be 0 for the quote-unquote first breath, right? Because if we look at the first breath, the ventilator thinks this is 1 breath, and they think this is a second breath, 1, 2. The expiratory volume of this quote-unquote first breath is 0 because the patient never breathes out, right? We talked about how the patient is still inspiring in, which is what prompts that second breath and prompts the double trigger. The flow never goes expiratory. It never goes quote-unquote negative on the flow scalar. So the 1 breath, the quote-unquote first breath, the expiratory volume will be 0. And then on the second breath, the expiratory volume will be 2 times the normal tidal volume, right? Because they took 2 breaths in. So let's say you're in volume control and it's set to 450. 450 cc's a tidal volume. What you'll see is the first breath, the expiratory volume will be 0. And then the second breath, the expiratory volume will be 900 cc's. And this is about, right? It's about, it's not exact, because they got essentially 2 full breaths without ever expiring. And we'll get into why this can be really problematic. So double triggering in general is diagnosed on your scalars, as we talked about. And it is caused when the patient wants to inspire for longer than the ventilator is letting them. So their inherent inspiratory time is longer than what the ventilator is set to. So let's say the I time, the inspiratory time on the ventilator is 1 second. If the patient says, you can give me that breath for 1 second, but I'm making these numbers up, but I want to actually inspire for 1.5 seconds. That is where you start to get double triggering because the ventilator stops the inspiratory flow after 1 second, but the patient is still inspiring for 0.5 more seconds. So then the ventilator senses that, thinks it's a separate additional breath, and gives another breath. All right, so the patient continues to inspire after the vent is done delivering, thus prompting a second breath. The solution for this hopefully sounds straightforward now that we understand the topic, and the solution is that you increase the inspiratory time. Right, so you prolong their inspiratory time. You prolong the time the ventilator is delivering the breath. Because if they want to breathe in for 1.5 seconds and the inspiratory time is only 1 second, increasing the inspiratory time to 1.5 seconds will stop the double triggering, right? Because your flow or your pressure scaler, right, that's your PEEP, patient breathes in, vent says, hey, they're breathing in, delivers a breath. The inspiratory time is the 1.5 seconds the patient wants it. The patient stops breathing in, the ventilator stops delivering the breath, and then it's done. Rather than PEEP, patient breathes in, the ventilator gives them an inspiratory time of 1 second, but the patient is still breathing in, so you get this negative deflection again in the pressure scaler while the patient continues to breathe in and cause negative pressure on the ET tube. The ventilator then says, hey, wait, they want a second breath, delivers a second breath before it goes back down, right? So prolonging the inspiratory time. Another way to think about this is decreasing the flow you might hear, but in volume control, the flow is essentially a result of the inspiratory time and the tidal volume. If you're delivering 500 cc's over 1 second, the flow is going to be 500 cc's per second. Right? So decreasing the flow essentially just means prolonging the inspiratory time. The other thing you can do is you can increase the tidal volume being delivered, right? Because this will also, decrease the flow, because if you're, I shouldn't say it'll decrease the flow, but if you increase the tidal volume, the amount of that breath, that inspiratory effort that the patient is giving you, you can match the tidal volume they want and thus stop them from prompting that second breath. Now, this gets a little tricky, right? Because let's say someone has severe ARDS, and we've talked about ARDS a number of times. It's in our critical care playlist. There's one there. I think we've talked about it a handful of other times in here. So we'll link some of those videos in the video description. But in ARDS, what you're trying to do is target 6 cc's of tidal volume per kg of ideal body weight. That's one of the ARDS endpoints. So if someone is double triggering, increasing their tidal volume would actually get you off of this 6 cc's per kg if that's what they were set at. So if you increase them to, 8 cc's per kg because they're double triggering, that might not be in line with your endpoints. So if you are in a tight spot and you have no other options, you could increase their sedation or consider neuromuscular blockade, paralytic in severe ARDS. But this should be a last-ditch effort. Do keep in mind, sometimes there's a happier medium. Because remember, they're going to be seeing, as we said, double volume when they double trigger like this. So let's say they're set at 6 cc's per kg, nice and pretty, right? And they're actually double triggering. What they're actually getting is 12 cc's per kg, which is a ton, right? So if you maybe increase them to 6.5 or 7 cc's per kg, it might eliminate their double triggering, and they actually would be a lot better off in terms of giving them that appropriate tidal volume for their ideal body weight that ARDS wants us to give. So do keep that in mind, that when you're double triggering, oftentimes the patient is getting a lot more tidal volume than what you have them set at. So to get started, Auto-PEEP or intrinsic PEEP or breath stacking or air trapping, I should say PEEP with the little I after it, stands for intrinsic PEEP. I for intrinsic and then PEEP. What is it? So these are the scalars here, and we're going to come back to this because it's nice to demonstrate a lot of these things on these scalars. But to get into some of the introductory knowledge, what is Auto-PEEP or breath stacking or intrinsic PEEP? Well, it in general occurs when a patient does not have enough time to fully expire before another breath is delivered. And this is primarily a concept that occurs when a patient is intubated or on a ventilator, right? Because we set a lot of what that patient is going to experience, how fast they have to breathe, how much volume or their tidal volume that they have to take with each breath, how much time they have to inspire and expire. All these things are things we can set on the ventilator. So this is often a self-inflicted wound that usually is secondary to some kind of underlying disease state or illness that the patient has, often probably the reason they ended up on the ventilator in the first place. And what happens when the patient does not have enough time to fully expire their full breath, aka the ventilator gives them a breath in, and then they're blowing out that breath, they're expiring that breath, but before they're done expiring that full breath, the ventilator delivers them another breath. So what happens, if you can picture it, is that this leads to an amount of retained volume in the lungs that builds up over time. And that volume building up over time is what causes the auto-PEEP, or the intrinsic PEEP, or the breath stacking, or the air trapping. Again, 4 terms all for the same concept. So to try to understand this a little bit better, I drew out a really crummy diagram of the trachea, airways, and lungs, and labeled them conveniently. So this is the trachea here, the windpipe. It goes into smaller and smaller, bronchi, bronchioles, and eventually into the terminal branch alveoli. So this is a very small airway, and then this is kind of the air sac, the alveoli at the end, where gas exchange occurs. And what we see with a breath being delivered by a ventilator, I didn't actually mean to delete these other little airways here, so we'll just draw those back in. But what we see with the breath being delivered by a ventilator is essentially, and there's some variability to this, right? There's volume control ventilation, where we set the amount of volume the patient gets. There's pressure control ventilation, where we set the amount of pressure a patient gets. For the sake of ease, all these concepts we're talking about, we're going to assume the patient is on a volume control mode of ventilation, where we set the amount of volume they're getting. And what that means is, let's just say we set the tidal volume, all right, TV for tidal volume, at 400 cc's, or 400 milliliters of air. What that means, in a simplified form, is that every breath, the ventilator is going to deliver 400 cc's of air, and that air is going to distribute into the large airways, the smaller airways, all the way down to the incredibly large number of alveoli in the lungs. And it's going to distribute throughout all those spaces that are exchanging air. And what happens then is the lungs inflate, right? So these lungs are going to inflate outwards as the ventilator pushes in those 400 cc's of air. When it's done pushing that in, the patient then breathes out. They expire. And what happens in a normal physiology of the lungs, or a ventilator that's well set up, is when the patient expires, right, these lungs move inward and they push all the air back out, and that air travels up the alveoli, into the small airways, into the large areas, into the trachea or windpipe, and then out of the patient. And in a perfect world, the amount of air expired is equal to the amount of air inspired. So there's a little different kind of verbiage on the ventilator itself, but for the sake of ease of concepts, we'll say tidal volume inspired with a little I, and then tidal volume expired with a little E. And again, in a perfect world, these things equal each other. The amount of air inspired is the amount of air expired. But what happens when the lungs are diseased? Right? Let's say that there's a bunch of disease in the lungs, and those lungs can't expire at a pace fast enough to empty all that volume before the ventilator says, oh, it's time to give you another breath, right? Because the other thing we said on the ventilator is the respiratory rate. So if I say that a patient has to breathe 20, what's going to be an easy divisible number, 30 times per minute, right? So that's one breath every 2 seconds. So if this patient takes longer than 2 seconds to fully expire that 400 cc's, the ventilator is going to stop them from breathing out, and it's going to push in another 400 cc's. So what we have then, so let's just say tidal volume inspired is 400, but the patient, for whatever reason, and we're going to go over a lot of those reasons below, can only expire 350 cc's of that tidal volume before another breath's prompted. Well, that means every single breath you're going to have a net positive 50 cc's of air left in the lungs. And if you're set at 30 breaths per minute, that means every single minute, 30 breaths times 50 cc's of trapped air, that's going to equal, oh boy, I'm going to show that I should go back and do more math in the classroom. I think that's about 1,500 cc's of trapped air in the lungs every minute. And you can picture if you're trapping that much air in the lungs every minute, you're going to increase the pressure in the lungs, right? And that pressure is essentially our intrinsic PEEP or our auto-PEEP. Because what PEEP is, for those of you that don't know, it stands for positive end expiratory pressure. So it's the amount of pressure that the lungs are seeing when they're done expiring air. And we actually set this value on the ventilator typically, right? You'll say PEEP of 5, because that PEEP is what kind of keeps those airways open, right? And you want a little PEEP. But auto-PEEP or intrinsic PEEP is PEEP that we did not set, that we don't want. It is PEEP that's added on to the PEEP you set on the ventilator. So let's say the intrinsic PEEP, is 15. The total pressure in the lungs then when the patient is done expiring is that intrinsic PEEP plus the PEEP you set. So it'd be 20, and that's a lot of pressure in the lungs. That's a lot of pressure they're seeing. So what causes this then? Why does this happen? Well, the thing that causes it is related to the physiology of the lungs. And it's kind of easy to think about if you break it down into a couple different things. So there's 3 things that affect a patient's ability to fully expire their tidal volume. One is essentially what we're doing with their ventilator. It's their minute ventilation. I wrote size. That's probably a confusing term. But you can just think minute ventilation, because what minute ventilation is the amount of volume they ventilate in a minute, which is going to be their tidal volume times their respiratory rate, right? And that's going to equal their minute ventilation. And we'll just write minute ventilation again just for the sake of ease. And this is something that we set on the ventilator, the tidal volume, and this is something we also set on the ventilator, the respiratory rate. So if we're setting these things really high, we sometimes can self-inflict auto-PEEP. Again, because sometimes we're setting the respiratory rate really high because we're trying to get them to blow off all this ventilation to clear some CO2, and we can shoot ourselves in the foot a little bit if they start auto-PEEPing. The other thing which is related, the other 2 things are related mostly to the patient's lungs. One is compliance of the respiratory system. So compliance is kind of like the elasticity of the lungs. Elasticity, that seems right, of the lungs. And it's going to, the mathematical equation, if you're interested, is change in volume over change in pressure. Not super important for the sake of this lecture. We're not going to dive into this concept in any amount of detail. But you can picture that if the lungs are more or less elastic, they're going to be able to push out that air either faster or slower, right? Because it's the change in volume over the change in pressure. So if your lungs are more elastic, you can kind of think of a balloon, they're going to push out that air at a certain pace compared to less elastic. And the time it takes for them to breathe that air out is going to affect their expiratory time. And if their expiratory time is too long, that's when you start to get breaths that are stacking on top of each other. The other thing, and the most common thing we probably think about with auto-PEEP, is the resistance of the respiratory system. Because as we drew up here, we have kind of these small airways, these alveoli, right? And they're a small airway, and then it ends on this kind of air sac, this balloon, and this is an alveoli. And the air we breathe in flows down these small airways into the alveoli. It's oxygen. The oxygen diffuses into the bloodstream. CO2 from the bloodstream diffuses into the alveolus, and then that breathes out into those larger and larger airways and eventually out the mouth. But what we will see happen with patients with certain diseases is that they get some kind of collapse or obstruction or resistance of these smaller airways. And you can picture if these smaller airways kind of are collapsing down or spasming, or there's mucus or disease, When the ventilator pushes in a breath, it causes positive pressure, right? Because it's pushing air in to the system, and that'll stent open these smaller airways. Well, when the ventilator's done pushing a breath in, this pressure, and again, there's some minutia to this, but from an introductory topic kind of standpoint, this pressure is no longer there stenting those airways open, or it's much less. There is still, for those of you interested in more of the nitty-gritty, there's still PEEP, and the PEEP is what you set, right, that expiratory pressure, but otherwise, there's not air flowing in, right, it's trying to flow out, and sometimes what will happen is these smaller airways can collapse down, or sometimes they're just spasming, or sometimes there's mucus. And when that happens, there's more airway resistance. So that causes an increase in airway resistance. And that increase in airway resistance sometimes means it takes longer for that air to flow out of the lungs. And again, if the expiratory phase is longer, is prolonged, they're more at risk to stack those breaths again. So that's what causes it, and I'm realizing this is maybe confusing verbiage, and I think I was trying to be clever, but let me explain what I meant. So that's what causes it. What does it cause? AKA, what does the AutoPEEP cause? Why do we care, right? That's always a question. Well, why do we care? Does it do anything? Does it do anything negative? Does it make a difference? Well, unfortunately, it does. It can cause a lot of really negative downstream effects, ranging from hypotension, so that's low blood pressure, right? And that's because if you're auto-PEEPing, right, you have, we'll draw it again. So here's your windpipe, here's your bronchi, here's your lungs. But this is all stuck in this thoracic cavity, right? It's stuck in your chest. And this is kind of a closed system. So if you're auto-PEEPing, we know that's increasing the pressure, right, in this system. Well, there's other things in this system too. You have a heart that sits right around here, and that heart has veins that dump blood into them, the superior vena cava and the inferior vena cava. And if the pressure in the system is really high, one could imagine that it's going to push on these veins and it's going to collapse them down, right? It's seeing all this pressure on both sides, and that can decrease venous return to the heart, decrease the amount of blood that can flow through these veins into the heart, because that pressure is pushing on those veins, and that can cause hypotension, decrease cardiac output. The other thing that can happen is ventilator-induced lung injury. Again, if these lungs are seeing this huge amount of increased pressure, it can actually damage the lungs, damage those small alveoli, right? These are really thin membraned little air sacs, and if they're seeing all this increased pressure pushing out on them, that can cause inflammation, damage, fibrosis, and they can stop working. It also is really uncomfortable for the patient. So it can cause patient-ventilator asynchrony or desynchrony. And you could picture, right, if that patient, every single time the vent's pushing a breath in, then they don't have time to push the air all the way out until the vent gives them another breath. And you can picture that over time that becomes very uncomfortable for the patient. It can also cause a concept called trigger asynchrony or desynchrony, and I'll go over that when we go to those scalars up top at the end of the lecture, but it can cause the patient to have trouble triggering a breath. And then the other thing you'll always hear about is increased dead space, and this is a really important topic, but it's one I wanted to explain a little bit more. What does that mean? And to do that, I think, again, I'm going to have to draw a nice set of lungs here. So you have your windpipe, your trachea, into your main stem bronchi, and again, those branch off into smaller and smaller little areas, right? And at the end of these little areas is going to be the alveoli, which is much smaller than this, because that looks to be the same size as the trachea, but it's much, much smaller than that. And that feeds into these lungs. So dead space is the amount of space in this whole system that is not exchanging gas, because the gas only occurs in the alveoli. So I'm going to erase this, and we'll say, if you were to magnify in a bunch, just kind of right here, what you would see is you'd have all these small, tiny alveoli, right? And the circles at the end are the alveolus where air is exchanged. And this is the only area gas is exchanged, right? Oxygen that's flowing in goes into the bloodstream. Carbon dioxide from the bloodstream goes into the alveolus and then flows out. There's no gas exchange in the bigger airways. It's all in the alveolus. So what you can imagine then is there's a amount of air in the system that's not exchanging gas. Right? I'm going to make up numbers here. Let's say that the alveoli represent, this is truly just a completely made up number, 40% of this system. So let's say the alveoli equal 40% of the system. That means 60% of the system are all these airways that are not exchanging gas. And that is dead space. Right? It's just the amount of air that's going to be sitting in these airways, because you take a breath in and that whole breath doesn't go to the alveolus, right? You're done breathing, it might get that far. And some of that air is in these small alveolus all throughout the lung, but some of the air is just sitting in the airways. And then you breathe carbon dioxide and you breathe it back out, right? And that carbon dioxide then travels, and some of it just sits in those airways and isn't breathed out the mouth. And that's called dead space. That's the amount of area in the lungs that's not exchanging gas. And increased dead space can lead to increased carbon dioxide levels because you're not able to ventilate off, you're not able to breathe off that carbon dioxide because there's so much dead space. And when you AutoPEEP, when you breath stack, that increased pressure can cause increased dead space because you're not breathing out all that volume. Right? And each breath you might start to breathe out less and less volume. So if ventilation is your tidal volume times your respiratory rate, that is your minute ventilation, right? We went over that equation up here. And if your minute ventilation is partially related to your tidal volume, and as we said, your tidal volume, let's say it's 400, but you start breath stacking, so you only breathe out 350 cc's. That means there's 50 cc's here that are never part of the gas exchange equation. And as you breath stack, as you AutoPEEP, as you get more and more intrinsic PEEP, this number might get less and less. You might start breathing in and out less and less air because that pressure is increasing. So now that pressure is so high that when the ventilator tries to breathe in 400 cc's, it can only get 300 in. But even with 300 in, there's so much air stuck in there. Now you're only pushing out 200, right? And your minute ventilation can go down and down and down. In addition to that, by hyperinflating all these areas, it can also increase dead space. So you have less ventilation, and that can cause increased CO2 retention or hypercapnia. All right, so that's what it causes, right? All bad stuff. Hypotension from the increased intrathoracic pressure, ventilator-induced lung injury from those increased intrinsic PEEP pressures the lungs are seeing, patient-ventilator asynchrony because it's so uncomfortable for that patient to be building up all that air in their lungs, and then increased dead space from decreased ability to fully ventilate. So how do we diagnose it and how do we manage it? Well, the way to diagnose it is actually over here. It's called, and we're going to go into the scalars after this, but it's called an expiratory hold maneuver. And what that means, if you can picture this, is let's actually maybe we'll go up to the scalar right now. We're just going to use the scalars one time, and then we're going to do more scalar work at the very end. So what an expiratory hold is, this is how you diagnose AutoPEEP. So an expiratory hold. You guys might be familiar with an inspiratory hold. That's how you determine a plateau pressure, a topic for a different video. But the expiratory hold essentially is you have the patient, you make the vent hold at the end of expiration. So what you'll see is a patient gets a breath in, right, expires that breath out, and you say to hold it, and you'll see this line kind of flatten out here. That's the expiratory hold. And what it should be at the same place. When you do the hold, it should stay right here. It shouldn't go up, because this is just the normal PEEP. But if you have AutoPEEP, right, so this is the normal PEEP here, you did an expiratory hold. This is the AutoPEEP, or the intrinsic PEEP. It's the difference between the normal PEEP that you set and then the amount of pressure in the lungs at the end of expiration, because PEEP is positive end expiratory pressure. So when you do an expiratory hold, it should just be the PEEP you set. It should just be the positive end expiratory pressure. But if you have auto-PEEP, that number on the expiratory hold will be higher than the PEEP you set, because that is the intrinsic PEEP, the auto-PEEP, the breath stacking, the amount of new pressure in the lungs because of that retained volume of air that's building up over time. And that vent will kick out a number when you do this expiratory hold maneuver, and that's called the auto-PEEP. So if we scroll back down, the one thing to note is this is very difficult if a patient is spontaneously breathing, right? Because let me erase that, spontaneously breathing. Because as we said, let's say hypothetically, you have a breath delivered, this is the pressure scalar, then you do an expiratory hold after the next breath, and it's starting to go up, but the patient doesn't like that, right? So they're going to breathe in, breathe out, and the scalar is going to get all weird, and you're not going to really get any real number. So if a patient's paralyzed, you certainly can do it. If they're deeply sedated and not working against the ventilator, you certainly can do it, but it's really difficult to do if a patient is spontaneously breathing. So then that begs the question, well then how do you diagnose it? And that is where we're going to dive into our scalars a little bit more. So if you guys aren't familiar with scalars, I'd really encourage you to check out some of our other lectures. We have introduction to scalars, and then a handful of other videos involving different desynchrony. And we'll link those in the video description and the video comments, because we don't want to belabor the points too much on what these scalars are. But just for a quick intro, this is the pressure scalar, right? Pressure as related to time. And this is all going to be, again, like we said, in volume control. This is the flow scalar as compared to time, and this is the volume scalar as compared to time. So what we see with AutoPEEP, if we can't do an expiratory hold, we can look to our scalars to gauge and get a little hints. So if we start with the volume curve, this is 0, right? That's 0 volume. And what you see in a normal breath is their volume goes up as they inspire, it goes down as they expire to 0, and then when the next breath comes, it goes up again, right? Makes sense. Let me get rid of those. In AutoPEEP, though, what you will see is they'll get their breath in, then they'll start to breathe out, but before they fully expire, that vent delivers them another breath in, right? And same thing happens. So you don't go down to 0 the way you should, which makes sense, right? Because again, let's pretend the tidal volume is 400 cc's. You get 400 cc's that come in, but then only 350 cc's out before the next breath. If we're being thorough, the way these scalars tend to look, though, is that there's a really prolonged expiratory phase, right? So it goes up, and then the patient takes a long time to breathe out, right? And then you get another breath in, then they take a long time to breathe out. And that's related to different pathologies, which we'll get into more in a little bit. The flow scalar with AutoPEEP can also be a hint, right? Because the flow is, you get flow in, then you get flow out, and then it returns to 0, right? It returns to 0 flow before the next breath, because there should be a slight kind of pause. There should be no flow, right? You get a breath in, breathe that out, pause, then another breath in. There should be a period where there's no flow in the circuit. Well, if you're auto-PEEPing or breath stacking, again, it means you don't have enough time to expire. So you get flow in, and then again, there's this prolonged expiratory phase, and it usually doesn't come back down to 0 before there's a second breath, right? So same thing, look again, prolonged expiratory phase, doesn't hit 0, another breath in. And that can be a hint on the scalars that there's AutoPEEP as well. Your flow is not returning to 0 with new breaths. And the pressure scalar is sometimes a little trickier. I think theoretically, so pressure goes up when you're delivering a breath, comes back down, and as you AutoPEEP, some would suggest that you should start to see this kind of marching up of the pressure scalar. right? Where this is kind of your AutoPEEP that's building up over time, although it doesn't seem to usually demonstrate that on the pressure scaler. It's a little more complex than that. But those are some hints for how you can diagnose it on scalers. Really, the flow scaler and the volume scaler are going to be your two biggest hints. I had a patient the other day who quite literally their expiratory phase was so long it took up almost the entire screen. The volume would go in and then it'd be this super prolonged expiratory phase, and then they would breath stack. It was a really difficult vent to manage, but you will see that with certain disease states, as we'll talk about. So if we scroll back down, what are those disease states? And that's something important, right? Because treating reversible causes is a major way you can manage this. So things we see this in, COPD and asthma are the two big ones, right? Because these have bronchospasm, bronchorestriction. Increased airway resistance is the name of the game in these. These patients have a really prolonged expiratory phase. In fact, just the diagnosis of COPD, prolonged expiratory phase is part of that diagnosis when they're not on a ventilator. You'll sit bedside and you'll have this inspiration and then this really long expiration. And you can see them with that prolonged expiratory phase. So that prolongation of the expiratory phase can really affect that. Also, patients with a lot of mucus can sometimes air trap as well. Treating the reversible causes, you're going to treat the underlying condition, right? COPD, asthma, steroids, nebulizer therapies to help with bronchoconstriction or bronchospasm. Sometimes magnesium is indicated. All this is treatment for COPD asthma. Another thing to always make sure is that the ET tube is not kinked. The endotracheal tube is not kinked, because kinking the endotracheal tube can sometimes cause AutoPEEP. If you picture the kink, right, we'll draw a tube here, and let's say there's like a little bit of a kink there. Well, when the breath gets pushed in, it can flatten out this kink, right? Because that's more positive pressure. And then when a patient is expiring, sometimes this kink will get even worse and they won't be able to expire outwards. So make sure that endotracheal tube is not kinked. That's an important one. In addition to that, sometimes we cause this ourselves, as we said, patients that we're trying to really increase their minute ventilation. Sorry, I realized I wrote minute ventilation up here for an easier shorthand. But yes, their minute ventilation, right? Because if we set the respiratory rate way high, we set the respiratory rate at 30, their tidal volume at 500, because we're really trying to get them to breathe a ton of air. They might have an acidosis. We're trying to help them breathe off. Well, as we said, respiratory rate of 30 means that they get one breath every 2 seconds, no matter what. We're telling the ventilator, we want you to give that breath no matter what. And their tidal volume of 500. So even if they don't have that prolonged of an expiratory phase, that can certainly mean patient breathes in, volume scaler is breathing out, and another breath comes in, right? Out, another breath comes in, out. And that can cause them to AutoPEEP because they just simply don't have enough time to breathe out that amount of tidal volume in 2 seconds. So sometimes this is a self-inflicted wound. So treating reversible causes is absolutely important. All right, increasing expiratory time. This makes sense, right? This is what you'd think. Well, if they need more time to expire, let's increase their expiratory time. How do we do that, though? Well, a couple ways. It's important to remember that a cycle here is 60 seconds, right? So when we're talking about respiratory rate 30, it's 30 breaths in 60 seconds. So you kind of have some limitations here. One way to increase the amount of time they can expire is to simply decrease the respiratory rate, right? If you have this is going to be a volume scaler. If you have the respiratory rate set at 30, I'm just drawing a bunch, that doesn't give them that much time to expire. Whereas if you have the respiratory rate set at 10, they can take all the time they need to expire, right? Because there's not a ventilator that's going to be giving them another breath right away. The other thing you can do is adjust the inspiratory time. It's actually something you set, right? On a ventilator, there's an I to E time, inspiratory to expiratory time. Oftentimes this is set like 1 to 2 maybe. And that means that the amount of time they get to inspire is half the amount of time they get to expire. So let's just say this is 1 breath, right? This, if you look at kind of the amount of time, this is going to be once compared to 2. It's going to be half. So for the sake of ease, if you were to set the breath at let's say
9 seconds they had to take each breath, which is unrealistic. That would mean that this is 3 seconds of time to inspire and 6 seconds time to expire. Well, if you could change this, you totally could. This is, again, for the sake of the example, you would never make the IDE 1 to 9, but let's say you made it 1 to 9. That means in this example, instead of 3 seconds, they get 1 second to expire, and I guess my math is still not quite on, but 9 seconds to expire. So 1, and then they have much more time to expire. So you can decrease the inspiratory time and essentially prolong their I to E ratio, aka give them more time to expire with each breath. The other thing you could do is decrease their tidal volume, which makes sense. If they only have 1 to 2 seconds to expire, and you're giving them, I'm just going to make up some ridiculous, you're making them breathe 800 cc's of air with each breath. Well, that means they're going to get these huge breaths that they're trying to expire out, and they might just simply not have enough time to expire out that huge breath. Whereas if you decrease the breath down to 400 cc's, for them that might be enough time to inspire and expire fully, and you could decrease their tidal volume. Well, obviously there's limitations to this depending on their physiology, but those would be the big things, right? Decrease respiratory rate, decrease tidal volume. These are supposed to be arrows down for those keeping track of my scribbles. Decrease tidal volume, and you can prolong the I to E ratio, aka decrease the amount of time they're taking to inspire each breath and increase the amount of time they're expiring each breath. Okay, excellent. Other things to note. We're almost done, I promise. So there's this thing called trigger asynchrony, or difficulty with a patient prompting the trigger. The trigger is what the vent needs to see to have the vent understand the patient is trying to take a breath in, and thus prompt the ventilator to give a breath. Because the ventilator's smart, right? If a patient breathes in, the vent is supposed to say, oh, okay, the patient's starting to breathe in. I'm going to deliver a breath with the settings you gave me, tidal volume, right? PEEP, I to E time. But the patient prompted this breath. They triggered this breath. Well, the way the ventilator often detects that is by detecting a change in pressure. And that change in pressure has to be this net change. And this is I'm going to put out a separate video on this topic in general. So if this is confusing, I promise we'll make it more clear in another video because it requires more time. But what this means is if you set the PEEP higher, so let's say you have an auto-PEEP, you're auto-PEEPing, you're breath stacking, and that auto-PEEP is 20. It's a high auto-PEEP. That patient will have a lot of trouble triggering a breath because they're trying to breathe in against all that stacked intrinsic PEEP, all that stacked air, and they have trouble mobilizing enough negative pressure to overcome that. But if you were to increase the PEEP they were set at, right, because this is their intrinsic PEEP. So if you were to say, all right, well, I'm going to set the PEEP at 14, just the normal PEEP, that is going to allow that patient to mobilize a breath a lot easier because there's already all this PEEP set to help them overcome the auto-PEEP. Again, I probably shouldn't even included it in here, but for sake of thoroughness, I did. But stay tuned for another video on that. And if worse comes to worse, let's say a patient's now hypotensive. They're not able to get in enough air. Their breath stacking so terrible. They're kind of on the cusp of coding. Disconnect them from the ventilator. Literally just take the endotracheal tube off the ventilator, and that patient, you can push on their chest even, they'll just breathe out all this air that's been breath stacked over time, and you'll immediately see their blood pressure get better. You'll see their plateau pressures getting better. Because it's another thing I probably should mention as diagnostic maneuvers. AutoPEEP increases plateau pressure. All right, so plateau pressure, for those of you that don't know, is the inspiratory pressure. So if you push a breath in, make the patient hold it, the ventilator then just detects the amount of pressure there. And you can guess that AutoPEEP would increase the inspiratory pressure, right? Because you have all this pressure built up in the lungs that if you push another breath in and then pause, you don't let any volume leave the lungs. It's an inspiratory hold. the AutoPEEP will be all that air that was already in the lung, in addition to the air you pushed in the lung during the inspiratory hold. So that's going to increase the plateau pressure. So when you disconnect a patient from the ventilator, push on their chest, let them breathe all that AutoPEEP, all that stacked breath out, hook them back onto the ventilator. You'll see that plateau pressure go back to normal, their blood pressure get better, and all that good stuff.
Hey everybody, and welcome back to another episode here at Whiteboard Medicine. Today we're going to be talking about a tricky concept. It was actually one requested by you all, so keep those requests coming. We appreciate it. Sometimes it takes us a minute to get them out, but we will get to them. And that is double triggering versus reverse triggering in mechanical ventilation. So this is part of our mechanical ventilation kind of advanced series on ventilator desynchrony. And we're going to dive into these two different types of ventilator desynchrony. They can be very tricky to tease out which is which, but we're going to give you some ways in which you can do it. And once you do, the management of them is quite different, which is why it's so important. As a reminder, these videos or episodes are never intended to be acted upon as medical advice. Stick around to the end of the episode for the full disclaimer. And then secondarily, shameless plug, this study guide as well as practice questions for all of our episodes we put on our Patreon page, so you can check that out, tagged in the description. We also have a weekly newsletter, and then both podcasts and YouTube episodes. So any interest, we'd love for you to join the community. Check out any of those. Shameless plugs now completed. Let's dive in. So to start with, overview of just ventilator desynchrony in general. So patient-ventilator desynchrony occurs when the timing or the magnitude of the ventilator assistance does not match the patient's own respiratory efforts. This can lead to things like ineffective ventilation, increased work of breathing, or even injury to the lung, ventilator-induced lung injury, also known as ventilator-associated lung injury. In addition to that, these types of desynchrony patterns can be identifiable, and you can intervene on them to improve patient-ventilator synchrony, because not only can it lead to these negative things, but frankly, it's quite uncomfortable for patients too, right? They're on a life support machine, a ventilator that is keeping them alive to some degree, otherwise they wouldn't be on it. And we want to make that as comfortable as we can for them. Two important types of desynchrony, and the two we're going to be talking about here are double triggering and reverse triggering. Okay, so start by defining these two things. What is double triggering and what is reverse triggering? Well, double triggering is when there's two delivered breaths in rapid succession with minimal exhalation time between them. Okay, so the ventilator gives the patient two separate breaths in rapid succession without enough time for the patient to exhale much, which then means they get double the tidal volume. And this is most often due to the patient's inspiratory effort extending beyond the set inspiratory time. So they essentially get a breath, right? Here's maybe a pressure scaler. They get a breath, but they're still breathing in even when the ventilator wants them to exhale, and they keep breathing in. They mobilize negative pressure, which then prompts the ventilator to give them a second breath without any time to exhale. So they get one breath, two breaths. They get twice the tidal volume, and that leads to ventilator-induced or associated lung injury, right? Reverse triggering, on the other hand, can look similar, but is from a completely different cause. And this is the ventilator-initiated breath actually induces this diaphragmatic contraction, kind of this reflex. And to be frank, the exact mechanism here is somewhat unknown. This is most likely what is happening. But why and to who exactly that happens to is still very nebulous. Okay. After the ventilator gives that inspiratory breath, there's this diaphragmatic contraction reflex. And that then makes the ventilator think the patient is wanting to trigger another breath, and thus it gives another breath. So it looks similar. There's one breath, second breath, but in double triggering, it's because the patient is trying to breathe longer than the ventilator is giving a breath for. Whereas in reverse triggering, the ventilator gives a breath, it causes the diaphragm to have this reflexive contraction, which then fools the ventilator into thinking they want another breath. Okay? Both, though, can cause 2 times the tidal volume, which can cause not only ventilator desynchrony and patient discomfort, but ventilator-induced lung injury as well. So mechanisms and causes, and we're going to dive more into these concepts too. That was just kind of the brief definitions, but mechanisms and causes. So mechanism of double triggering. As we said, a patient's inspiratory effort in double triggering continues past or beyond the ventilator's inspiratory time. So they're still trying to inhale, even after the ventilator's inspiratory time. This then creates flow and pressure that then makes the ventilator give a second breath. So the flow or pressure returns to baseline from the ventilator, but the patient still wants to inhale. So it immediately triggers another breath. Common causes here can be the biggest one, high patient drive. All right, those patients are taking huge breaths. It might be pain, might be anxiety, it might be compensatory for metabolic acidosis. Other things can cause it too. A really short inspiratory time can cause it. So let's say you set the inspiratory time. This is the amount of time in inspiration. It's something like 0.8 seconds. But the patient actually wants to inspire for 1.2 seconds. That means the patient keeps it inspiring for 0.4 seconds even after the ventilator has stopped giving that breath. That prolonged or extended inspiratory time then prompts the ventilator again to give a second immediate breath because that patient is still inhaling even after the breath is done. The other thing that can cause this is insufficient flow. This is particular to volume control modes. Volume control modes have a calculated flow based on the volume and respiratory rate, as well as the I time and some other things. But if the patient wants more flow of air, they're quote-unquote air hungry. This can lead to flow starvation, which is a type of ventilator desynchrony that we've talked about in previous episodes, linked in the mechanical ventilation playlist in the description, where we got tons of mechanical ventilation content. But this flow starvation can then lead to a second breath being delivered, okay? So mechanism and common causes of double triggering. What about mechanisms and common causes of reverse triggering? Very different than double triggering. The mechanism here is that the ventilator delivers a breath passively. The patient is not prompting that breath. And that passive breath stretches the patient's diaphragm and the respiratory muscles. This kind of stretch reflex then triggers this reflexive kind of diaphragmatic contraction that the ventilator mistakes for the patient wanting a breath, so the ventilator delivers a second immediate breath. And the common causes here are way different than double triggering. So reverse triggering causes can actually be from deep sedation or incomplete paralysis. Whereas, as we said, double triggering was because the patient actually has too much respiratory drive. In reverse triggering, the sedation actually might be too deep. High ventilator rates and large tidal volumes can kind of create more diaphragmatic stretch and lead to double triggering at times. And then we don't use things like controlled mandatory ventilation very often. Most of our ventilation is assist controlled. Controlled mandatory is that the ventilator just delivers the respiratory rate that you set, whereas AC assist controlled is that the ventilator will get you to that respiratory rate, but if the patient triggers a breath, it'll just support that breath. So the old school controlled mandatory ventilation mode, again, that we don't use, can lead to reverse triggering. But I think most often the times that I've seen it are deep sedation or incomplete paralysis. How do we differentiate these two? Well, there's a couple hints just in general, and then we'll talk about scalars or waveforms. So when it comes to double triggering and when it comes to reverse triggering, the first differentiator that we can use is the timing of patient effort, okay? Double triggering, the patient's effort is usually before or during the first breath, and then it persists into the exhalatory phase. This triggers a second breath almost immediately. Many of these patients have flow starvation, so you'll see them kind of take this robust inspiratory effort, and they'll still be inspiring even after the breath is done. Whereas reverse triggering, the ventilator gives the patient a breath, and after that breath is going in, the patient has this reflexive inspiratory effort. So it didn't precede the breath. The inspiratory effort started after the breath. Waveform signatures we're going to talk more about below. So I'll read these out now, but then we'll dive more into it in a second. The waveform signatures for double triggering are kind of two square decaying curves without much expiratory flow between breaths, back breaths. Again, we'll draw it out and talk more about it. Whereas reverse triggering is the single ventilator breath waveform followed by this kind of secondary negative deflection, which I'll draw out for everybody. All right, what else? Expiratory time The expiratory time in double triggering, nearly absent, right? Because they are not exhaling, they're still inhaling even when the ventilator wants them to exhale. Whereas reverse triggering, there's usually a normal amount of expiratory time after the machine breath. Patient effort usually overlaps the inspiratory phase, and this will make more sense with those scalars. All right, and then patient comfort. Patients who are double triggering often have dyspnea, accessory muscle use, and discomfort because their respiratory effort is increased compared to what the ventilator is giving them. Whereas patients who have reverse triggering, they're usually quiet, right? They might be passively ventilated. They might be deeply sedated. These patients do not have the degree of kind of visual discomfort that patients with double triggering have. Sedation, you can get double triggering at any sedation depth, and then reverse triggering is more common with deep sedation like we talked about. So let's get into the clinical implications. Actually, before we do that, I'm going to scroll down to waveforms. I should have put these in the other order, but let's talk about the waveforms now. So double triggering, I'm just going to write kind of increased inspiratory phase. Reverse triggering, I'm going to write diaphragmatic reflex, just so that people kind of have those buzzwords to think about while we write them out. So we're going to do these scalars based on volume control. And the scalars are waveforms, right? There's pressure versus time, flow versus time, and there's volume versus time. And the pressure scalar, maybe we'll, for the sake of room, start with the pressure scalar here. The pressure scalar normally looks something like this. So it's pressure and time. And this is your PEEP, is where it starts. We've had a bunch of videos on scalars, so check those videos and episodes, both podcasts and YouTube. So check those on the playlist. But this is your PEEP. It's not at zero pressure. And then you get your pressure goes up, comes back down, right? Goes up, comes back down. Reverse triggering, double triggering is, you'll see this kind of negative deflection. This is the patient starting to inhale, right? And then the ventilator says, okay, that's going to trigger a breath for me. So I'm going to give that breath, and it'll then want to exhale, but the patient will still be inhaling. So you get this negative deflection that then prompts a second breath. Okay? So see that these are two immediate breaths, breath 1 and breath 2. And there's very little exhalatory time here. And you get these negative deflections, which are where the patient is giving continued inspiratory effort that then prompts that second breath. And in the volume scalar, so if we did volume over time, what you'll see is normal volume scalar looks something like this, right? So that's a normal volume scalar. This is 0 volume. This is your tidal volume you set at. It goes up to the tidal volume, down to 0. But in double triggering, you get twice as much tidal volume, because there's these two breaths combined into one. So if you set your tidal volume at 300 cc's, right, they get 300 cc's in this breath. But here they actually get 600 cc's because they have two breaths that were given at once. Reverse triggering, on the other hand, if we draw out the scalars, this will be pressure versus time. We know what normal looks like already. This is what normal looks like. You'll see this, right? You won't see a downward deflection. The ventilator will just give a passive breath. Okay, but then when we come back down, you do see this downward deflection, and this is that diaphragmatic reflex that is causing the patient to kind of reflexively inhale in. And if it causes true kind of reverse triggering, where it triggers the ventilator, it'll look like this: passive breath, right, comes back down, and then you get this kind of diaphragmatic reflex, but that then triggers a second breath. So you don't have the initial, there's no initial patient effort. You see this kind of reflexive patient effort right after that sometimes will trigger a second breath, breath 1, breath 2, and it sometimes won't. And volume scalar would look the same, volume and time. Normal breath, as we did. Abnormal breath, twice as high, right? 300 cc's, if that's what you set the tidal volume at, compared to 600. So the scalars look similar, but the things that would stick out would be, in double triggering, you usually have patient effort to start the breath, whereas in reverse triggering, there's no patient effort. Reverse triggering, you usually will have a negative deflection afterwards, and that sometimes prompts a breath and sometimes doesn't. Okay? And then we went through some of the other things that stick out, not related to scalars above. So let's get into the clinical implications then. So the big risks here are very similar. Double triggering risks of things like volume trauma and barotrauma, because you're getting these huge tidal volumes because it's the sum of those two breaths like we talked about. The way to manage it is increase the inspiratory time, increase the I time, or adjust the inspiratory flow, give them more flow to meet the patient's needs. You can reduce the respiratory drive by treating pain, anxiety, adjust sedation. You don't want to start by adjusting, like making a patient into deep sedation. Try these other things first. Adjust the inspiratory time, flow. You can switch modes. Again, we don't really use these much, but sometimes if you switch from volume control to pressure control liberates flow a little bit. Patients can kind of determine their own flow. So if patients are having a lot of double triggering or flow starvation in volume control, if you switch them to pressure control, they tend to like that better. So my approach is I adjust the I time, I look at the flow rate, I do all that, I make sure they're not in pain, make sure they're not anxious. I will sometimes switch modes to pressure control, and if I can't fix it at all, and if it's causing these large tidal volumes that are increasing barotrauma, I sometimes will increase their sedation, but that's kind of a last step. Reverse triggering risks the same thing, right? Breath stacking, increased pressures, barotrauma, lung injury, all that kind of stuff. What you do for breath stacking, for reverse triggering is different though. Sometimes lightening sedation can actually help reverse triggering, right? The exact opposite of what helps double triggering. Sometimes, if you deepen it briefly, you can kind of recouple the reflex. But this does not this is not a long-term solution, if that makes sense. Adjust ventilator settings. Reduce the set rate or volume to minimize the diaphragmatic stress. So if you can decrease the tidal volume or decrease the respiratory rate, sometimes that can help if a patient can tolerate that. And then again, adjusting modes can help too. But really, lightening sedation is something to try, dropping the tidal volume or respiratory rate. And then if you have to try to change modes, you can. Okay, so quick reference for double triggering and reverse triggering, and this will be the end of it. Again, this study guide as well as practice questions will be on our Patreon page if you have an interest in having access to it. But the reference guide here, effort timing, double triggering effort overlaps and outlasts the machine. That's why that pressure scalar, you get patient effort, they get a breath, and then that effort continues, so they get a second breath. Okay. In reverse triggering, effort follows the machine, right? So you don't have patient effort to trigger the breath. That's just the ventilator breath. And then you kind of get that patient effort, which is not really patient effort, just diaphragmatic reflex afterwards. Ventilator mode, you can see it in volume control, especially with short inspiratory times for double triggering, whereas reverse triggering is more in controlled modes, which you don't use too often anyway. Sedation, high drive usually triggers double triggering. Deep sedation, on the other hand, triggers reverse triggering. Primary fix is to match the inspiratory time and flow rate to the patient for double triggering, adjust rate and volume or sedation for reverse triggering. So hopefully that's kind of a nice quick reference reminder.
We'll be talking about what ineffective triggering is. We'll be talking about what causes it, waveform analysis, how to approach it, how to fix it, all that good stuff. A couple plugs quickly. For those of you new to the channel or the platform, this is channel Whiteboard Medicine. We got a podcast, we got a YouTube channel, we got a YouTube members, Patreon page, weekly newsletter, all that good stuff. We actually upload all the study guides and practice questions to both our YouTube members as well as Patreon members. We'll link all that in this episode's description if you have an interest in checking this out, either for practice questions or the study guides. And we have a whole series on mechanical ventilation, guys. We probably got 10 videos out there on all sorts of stuff, 10 videos and podcasts. So we'll link the playlist to those in this video description as well. And if you're interested in a newsletter too, weekly newsletter, it's public health and emerging infectious disease primarily, but it's totally free. You can obviously unsubscribe whenever you want to. So low risk in our mind, and hopefully it brings some decent content. We got I think close to 500 people on there by now. It's relatively new, so we'd love for more people to join. And then last thing, as always, not intended to be acted upon as medical advice. None of the things you hear. Full disclaimer at the end of the episode, also in the episode description, as always needs to be said. Nonetheless, enough with the plugs. Let's dive in. Mechanical ventilation, advanced, desynchrony, ineffective triggering. So what is ventilator desynchrony? Probably a good first thing just to make sure we're all starting on the same page. So ventilator desynchrony occurs when the patient's respiratory efforts are not appropriately matched by the ventilator. The ventilator is a machine, and as a machine, we have to set it to provide each breath in a certain way, and there's limitations to that way. And the way in which it's providing that breath may not be how the patient wants to receive that breath, whether it's because of pressure or volume or flow of that breath can sometimes cause issues. So this can result in all the things we've seen: increased work of breathing, patient discomfort, sedation needs, because sometimes folks, sedate patients to make them more synchronous, and then potentially worse outcomes too. All these things can lead to prolonged ventilatory times or even ventilator-induced lung injury, all that kind of stuff. What about ineffective triggering specifically? Definition and core concept. So ineffective triggering happens when the patient tries to initiate a breath. They initiate an inspiratory effort, but that actually fails to trigger a ventilator-assisted breath. So the patient wants to inhale, but the ventilator doesn't see it. It doesn't pick it up, so it doesn't give a breath. And as a result, the patient's effort's wasted. They tried to take a breath and no breath was given. And to understand this a little bit, just to go back a notch, it helps to understand how ventilators give breath. So, the vast majority of ventilator settings are AC, assist control. And this could be AC-VC, volume control, AC-PC, pressure control. But this AC, this assist control, is important because what this means is that the ventilator is always watching for when the patient tries to take a breath. And when the patient tries to take a breath, the ventilator detects it and then it gives a breath. Okay? So it is assisting the patient. The old school way was that you would just, the ventilator would just give 20 breaths, if that's what you set it on, per minute, and that, didn't matter if the patient was trying to take a breath or not trying to take a breath, and you can imagine that's really uncomfortable. So the newer models, for as long as I've known, but I haven't been in the world that long, as long as some of you probably, but they try to sync up when they give a breath to when the patient tries to take a breath. So because of that, there's certain parameters that are set to help the ventilator know when the patient's trying to take a breath. And when those parameters aren't met, that patient tried to take a breath, the ventilator didn't notice, and as such, it did not give a breath, so then it was a wasted effort. It can be really uncomfortable for patients. So that's ineffective triggering, when the patient tries to take a breath in, but the ventilator doesn't recognize it, so it does not give a breath. There is an ineffective trigger. So physiology and pathophysiology of this. Well, normal triggering, as we said, ventilators detect a breath based on a couple different things. One of those things can be a pressure trigger, and one can be a flow trigger. You set this on the ventilator. The pressure trigger is when there's a drop in airway pressure, usually 1 to 2 centimeters below the baseline. Again, this is set on the ventilator because you have a patient who's got a endotracheal tube in their mouth, into their trachea, attached to the ventilator. This is a closed circuit. So when the patient tries to breathe in, it creates negative pressure in that circuit, right? You try to take a breath in, that's going to create negative pressure. And that negative pressure, if you have a pressure trigger, drops the airway pressure, and then that prompts the ventilator to be like, hey, they're trying to take a breath, and then they give a breath. You also can have the ventilator set to be a flow trigger, though. And this is if there's a drop in flow, usually 1 to 3 liters per minute below baseline, that will then trigger a breath. Either one of these triggers work. They both work totally fine, pressure trigger or flow trigger, but they are settings on the ventilator. And you can change how robust this trigger is. You can increase or decrease the pressure or flow trigger, at least to some degree, for different kind of clinical indications that we'll talk about. So why does it fail then? Well, ineffective triggering occurs when the patient effort is too weak to meet the trigger threshold. That's one of the times, right? If you've set a pressure trigger at 2 centimeters below baseline, but the patient can only mobilize 1 centimeter of kind of negative airway pressure because they're too weak, that won't trigger because it won't meet the threshold that you set, which was 2 centimeters below baseline of pressure. AutoPEEP, we have a whole bunch of videos out there on AutoPEEP, also known as breath stacking. When AutoPEEP happens, essentially what's happening is you have not provided enough expiratory time, which means that every breath the ventilator is giving, the patient did not fully exhale the entirety of their last breath. So then you start building up extra air in the lungs, because each breath the patient is exhaling only, choose whatever you want, 90% of the air. So 10% of it's still in the lungs when the next breath's given, and that compounds over time. And this creates something called intrinsic PEEP. PEEP is positive end expiratory pressure. And, again, check out those other episodes on AutoPEEP, because this is a really complex, really important, but really complex topic. So we're not going to do its justice in this video alone. Video or podcast if you're listening. We've been a YouTube channel for so much longer than a podcast that we sometimes still say video. But yes, this episode, either podcast or YouTube. But what AutoPEEP does is it generates intrinsic PEEP. PEEP is positive end expiratory pressure. And PEEP is something you set. Many people are probably familiar with PEEP. But intrinsic PEEP happens when you get breath stacking, because all that air building up in the lungs creates pressure. And that pressure then, when you try to take a breath, so we're just going to make this up. Let's say the PEEP is set at 5, but I did a bad job in my ventilator settings and I'm not paying attention, so AutoPEEP is developing. And let's say that AutoPEEP creates an intrinsic PEEP, we'll just say I-PEEP, of, let's just make it so it's terrible, at 10. Okay, so the PEEP's set at 5, but intrinsic PEEP has built up from breath stacking to 10, so there's actually 15 of PEEP. But my pressure trigger is 1 to 2 centimeters below the baseline being 5. So my pressure trigger, you need to get to a PEEP of 3 to trigger a breath. Well, when I was at a PEEP of 5, that was probably no big deal, right? Someone tries to breathe in, it drops the PEEP from 5 down to 3, and the ventilator says, hey, they want a breath, give it to them. But now I have all this intrinsic PEEP, and now my effective PEEP is actually 15. So that patient, instead of going from 5 to 3, has to go from 15 to 3, which means instead of just -2 pressure from 5 to 3, they actually have to get -12 pressure. Obviously a much harder thing to do. So AutoPEEP creating intrinsic PEEP can lead to ineffective triggering. Ventilator settings are too insensitive. You essentially just set your triggers too high. That can lead to ineffective triggering. You need to be a little more liberal, a little easier going on your either flow or pressure trigger. And then muscle weakness or sedation paralysis obviously reduces effort and can lead to ineffective triggering. So really, a lot of these are, I think, the two categories. One is patient-centric, and that is the patient is too weak, or there's a kind of too much sedation. And the other ones are ventilator-centric, aka AutoPEEP is building up, or the ventilator settings are too insensitive from where their triggers are set, either pressure or flow trigger. So waveform recognition. So ineffective triggering can be seen on the waveforms or scalars. For those unfamiliar with scalars, we've had a whole bunch of episodes on that too. Again, linked in that mechanical ventilation playlist in the description. Definitely check those out if you're interested. But there's 3. We're going to assume that the patient is in the volume control mode, ACVC. There's 2 scalars to look at when it comes to ineffective triggering. One is the pressure time scalar, and the other is the flow time scalar. To make this easier, we're going to focus on the pressure time scalar. And the pressure time scalar in volume control usually looks like this. It starts not at 0 because this is your PEEP. Okay? And then a breath is given and the pressure goes up, gets to the peak inspiratory pressure and comes back down. If a patient triggers a breath, you'll usually see the slight negative dip, right? Because that breath created negative pressure, and that actually triggers the ventilator to then give this breath, right? So this is a patient-triggered breath when you see this dip. Without the dip, this is a ventilator-given breath. With ineffective triggering, what you'll see is you'll see this dip, but it won't trigger a breath, right? See that? So you see the dip, but no breath is given. You'll get this negative deflection in the pressure scalar without a subsequent breath being given. So on the ventilator screen, you'll see a small deflection, but no subsequent breath being given following that deflection. That is ineffective triggering. Seen as a small negative blip in pressure. You'll see a similar blip in the flow scalar as well. Not a lot of people use esophageal pressure monitoring or diaphragmatic EMG, but there is certain ways you can identify this if you have those monitoring tactics too. If you see this, you should really think about why it's happening, which we'll talk more about next.
So just examples to drive the point home on scalars. If you are looking at the flow scalar, you'll see a brief dip with no breath following. If you're looking at the pressure scalar, you'll see that small negative deflection without a breath following. There's no volume delivered despite patient effort, obviously, because no breath was given. Causes, if we dive more into it, as we mentioned, patient-related causes, weak effort from fatigue, neuromuscular disease, sedation, too high a respiratory rate, so they're tired, can all lead to ineffective triggering because they can't mobilize that flow or pressure to trigger the ventilator. Ventilator-related causes, insensitive trigger settings, so you need to make the pressure or flow trigger less stringent. Or inappropriate modes. We mentioned how all modes are usually, shouldn't say that, but most modes are usually assist control, but not all of them are. So if you're in a controlled mode that is not assist control, that might also lead to ineffective triggering because these patients' modes don't have the same triggering modalities as assist control does. Lung mechanics, such as Auto-PEEP, right, creating that intrinsic PEEP, which then leads to patients' inability to overcome that intrinsic PEEP to get a breath triggered. And then asynchrony, often asynchrony things coexist. So if there's other desynchrony like double triggering or reverse triggering, these in general can lead to changes in kind of intrinsic PEEP and volumes delivered and all that, and all these can lead to ineffective triggering too. So desynchronies often come together. We've talked about double triggering and reverse triggering and flow starvation on the channel before. Another shout out for that playlist of mechanical ventilation linked in the description. Management strategies. So these are related to the causes, which makes sense. The first is going to be improve the trigger sensitivity. Easy. Either lower the flow or the pressure trigger threshold. So if it was flow, instead of 3 liters per minute, decrease it to 1 liter per minute. If it's pressure, instead of 2 below the baseline, make it 1 below the baseline. So just change the trigger, right? Make it more sensitive. Fix AutoPEEP. This is super important. Again, we've talked about AutoPEEP a bunch of times. We're not going to dive into it here. So definitely check out those other episodes. But things like decreasing respiratory rate, increasing flow, decreasing the I/E ratio, decreasing tidal volume, all these things help overcome AutoPEEP. Adjust the mode if you are in a weird mode. Hopefully everyone is using AC assist control modes, but if you're not, adjusting the mode can help. Optimize sedation. If the patient is super deeply sedated and having ineffective triggering, can you lighten their sedation, right? Too deep suppresses their respiratory effort. So see if you can lighten it. Sometimes that will fix ineffective triggering. And then if you have advanced monitoring tools, these can be helpful in detecting ineffective triggering and its causes. So esophageal pressure monitoring, diaphragmatic electrical activity. We don't tend to use these devices, but they are out there and some people do use them. So from a clinical standpoint, just to finish things up, ineffective triggering can increase the work of breathing. A patient is trying to take a breath but receives no assistance. It can increase the number of ventilator days because poor synchrony prolongs weaning. Sometimes this leads to increased sedation because people try to sedate the desynchrony away. And then it decreases patient comfort, certainly. So there are some significant clinical impacts of ineffective triggering. In summary, look at the waveforms. Small pressure dips or flow dips without a breath being delivered suggests ineffective triggering. Think about common causes, both patient-centric, weak to sedated, or ventilator-centric. Triggers are not appropriate, or there's Auto-PEEP. Think about fixes. Obviously, get rid of Auto-PEEP if it's there, increase the trigger sensitivity, lighten sedation, and then know that there is risk of ineffective triggering that can lead to worsening ventilator desynchrony, delaying ventilator liberation, decreasing patient comfort, all that good stuff. All right, hopefully that was helpful. Let us know what thoughts, comments, questions you have. If you want to check out this study guide, again, it will be posted in our YouTube members as well as Patreon members. And if you have an interest in podcasts or YouTube videos, we'll have all that linked. And then, again, we have that weekly newsletter, so a bunch of shout outs. We appreciate you all. Stay well, keep learning. We'll see you next time.
Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.